I'm an orthopedic hip and knee surgeon. I specialize in hip and knee, and it gives me great pleasure to talk today about minimally invasive anterior hip replacement, or the AMIS or AMIS technique. And I'm going to try and provide as much information regarding this approach, which you may or may not be familiar with, and compare it to other approaches and tell you why I use it and when do I use it, and the techniques and the literature and the outcomes and my own results, and then a summary of the outcomes. Next slide, please. So the talk today is going to be divided into these sections, focusing on the gold standard, which is the posterior approach, the anterior approach, and the difference between that and the posterior approach, comparison with regards to results, advantages, disadvantages, what the literature says, the actual technique, one case review as an example, some outcomes from my own results and other outcomes, and then just a summary. Next slide, please. So most people are familiar with, generally speaking, either the lateral or the posterior approach, although the lateral approach or the hard hinge is gaining less favor now, and the posterior approach is now the gold standard in the UK for hip replacement surgery. It works very well, and nobody can ever fault the posterior approach. The only thing that I wanted to compare with is the analysis between the complications and also the outcomes with regards to the posterior approach and the anterior approach. And generally speaking, the posterior approach, you split the gluteus maximus and you split the rotators at the back of the hip in order to gain access to the hip. So next slide, please. And this approach is very extensile. It is used in primary, complex, and revision surgery, and it is what I definitely use in revision surgery for its extensility, or being able to be, shall we say, more amenable in case of revision surgery and in case of complex procedures, because it allows access to the hip, and it gives good exposure both to the femur, the thigh bone, and the acetabulum, which is the shell. Now, the only disadvantage that I noticed with regards to the anterior approach, the next slide, please, compared to the posterior approach, is the recovery time because of the muscle cutting and the amount of pain that they're in. And I've compared the two together and looked at the results. But just to give you some background, the anterior approach, rather than going from the back, we go through the front in an intermuscular plane. So finding the plane between two layers of muscles, the superficial layer and the deep layer, getting into the capsule just underneath the rectus femoris and going straight onto the hip joint from the front. And hence it is an intermuscular plane rather than a muscle cutting plane. And that's the main sort of USP or selling point for this approach, is that you preserve the muscles at the front, but also at the back, which is very important from a dislocation rate point of view. So the anterior approach is an approach that comes through the front of the hip. It lends itself to being an intermuscular plane. It is a, next slide, please. It offers a preservation of the musculature, specifically the ones that we're interested in are both at the front and the back, but mainly the back muscles, so the rotators, and hence it lowers the risk of dislocation. Next slide, please. The advantages of the anterior approach, generally in comparison to the posterior approach, and this is based on my own findings as well as the literature, is that there are no muscles being damaged or cut. Certainly speaking, there's a shorter stay. If you look at most of the results, the shorter rehabilitation, these patients do recover quicker. There is what I call a reduced risk of dislocation theoretically, because you're not touching the capsule at the back and the rotators at the back, you're preserving those. And there's evidence to suggest that there's a slightly better muscle tone, and hence they walk quicker. They tend to have less pain, and they return to activities quicker. And next slide, please. And this is my evidence for the approach. So it's based on evidence-based medicine and several publications, some of them old and some of them new. It is not a new approach. It is certainly an approach that's been around, but it has seen a resurgence both in Europe, the US, and Australia. Now, next slide, please. The most important thing is to compare the gold standard with the anterior approach, so comparing the posterior approach and the anterior approach. And if you look at this slide from the patient perspective point of view, there's definitely a lower risk of dislocation, and that's very, very important, where you can see the dislocation rate is less than 1% as opposed to 3 to 4% in the posterior approach. And if you look at the mean length of stay or the days in hospital, there's a day's difference on average, which is important in this day and age where you want to get patients quicker and you want to get them up quicker and they rehab faster. And also, if you look at the outcomes from discharge to home versus rehab facility, anterior hip replacement patients tend to go home more so than patients having a posterior approach where they may require a period of rehabilitation. Next slide, please. So if you look at the comparison between the advantages and disadvantages, the anterior has a swift rehabilitation overall, and it has a lower risk of dislocation. But there are disadvantages compared to the posterior approach. So it has a longer learning curve. You need to at least be exposed, I would say, between 50 to 100 cases. There have been incidences of perioperative femoral fractures. If you go the wrong way down the femur, it can lead to fractures. Sometimes, if it is a prolonged operation, can lead to blood loss and can lead to longer duration of surgery. However, the advantages are the lower risk of dislocation. Once you overcome the learning curve, they can lead to advantages to the patients, and the patients do inquire about them as they read about it more and more and find about it on the internet. But they also come and from other patients. I've seen patients who come in and ask about the procedure where somebody has had it done in Europe or the US and they've had the anterior approach, and they inquire about that versus the posterior approach. And I always give the patients both options as long as they're suitable, and I tell them the advantages and disadvantages. But I always say that the posterior approach is still a gold standard in the UK. Next slide, please. The comparison, again, just to give you some anatomy. So we go through the intermuscular plane. Sorry if the picture is a bit hazy, but we go into the intermuscular plane, going direct anterior through that plane, avoiding the lateral cutaneous nerve of the thigh, which supplies sensation only to the anterolateral aspect of the thigh. And then you're down onto the capsule, as opposed to going from the back where you cut the gluteus and the rotators, is sometimes piriformis as well, to get exposure. Next slide, please. So the risks of the anterior approach, there's a slightly higher risk of fracture of the femur specifically, because you are entering it from the front. You are reaming retrograde rather than antegrade. Slight risk of bleeding can happen, especially if it's a prolonged procedure. I've seen it happen in the learning curve and when you do more complex or more difficult anterior hip replacements. I use XRAY intraoperatively, which gives me a much better sort of outcome with regards to the position of the implants. And I recommend that you use XRAY, especially at the beginning, because it helps to improve the position of the implants, and you can see where your placement of the implants, both on the femoral side and the tibial side. The nerve injury, there's a small risk of what we call nerve injury to the lateral cutaneous nerve of the thigh, which supplies sensation to the anterolateral aspect and sometimes can cause irritation. The disadvantage also is that it is not really an extensile approach in case you're doing revision, and there is a learning curve. You have to go and learn this. I've spent time in Australia to learn the anterior approach and then developed it, and when I came here to the UK. And you have to, if you're either using a traction table or if you're not using a traction table, then you have to have two people assisting you on doing the anterior hip. But if you're not, then you can have a traction table. And there have been some instances of traction injuries, including nerve injury or ankle fracture sometimes if it's too robust. The bleeding, next slide please, can happen during the procedure due to the position of the vessels. You have to ligate the vessels as you're going in through the front in order to avoid any bleeding after the operation. And there are some capsular vessels that run on the supralateral part of the neck, mainly branches of the medial circumflex femoral artery, that can sometimes cause bleeding as well, and that they have to be controlled. Next slide, please. The risk of fracture is related to how we get in the femoral component into the femur, because when we're doing the prefemoral preparation, you have to go as lateral as possible without breaching the trochanter, obviously. In the anterior approach, this can be slightly more difficult because the trochanter is behind and the access to it can be a bit tricky. So you have to expose that area clearly, do a few muscle minor releases of the capsule at the back in order to be able to position the implant in the correct position. Next slide, please. The nerve that is most at risk is the lateral femorocutaneous nerve of the thigh, which can become injured either due to direct trauma or due to traction. And this nerve doesn't control any motor, doesn't have any motor function, but it does, if it is injured, it can cause irritation to the skin in that area. And you have to be very careful. What I do in order to avoid this is that I go sort of over the muscle into the muscle sheath and take the sheath on top so that it basically lifts the nerve out of the way from the sheath of tensor fascia lata, basically. And you go over the muscle into the sheath, and then you go into the second layer. Next slide, please. With this approach, I cannot stress the importance of choosing your patients well. And some say that this is bias. However, it is important to recognize the limitations of the approach, and that's the ability to understand when the approach is feasible and when it is not feasible, and to recognize when to use the approach correctly. Generally speaking, I recommend that the approach is used in a patient with good bone stock, obviously with evidence of severe arthritis. Ideally, with normal anatomy, you want to avoid the patients who have dysplasia or deformity or previous trauma, because it makes it much more difficult. Ideally, you would want to avoid patients who have had previous hip surgery. Hip arthroscopy is okay. Ideally, at the start, you should try and aim to do low BMI patients. No previous history of infection in the hip, and certainly not AVN. There are some papers to suggest that AVN is not, it is not recommended to do the anterior approach because the bone can sometimes have areas of severe sclerosis, and then you need to have a good exposure and be prepared to use cement as well, and be prepared to open the canal, which sometimes can be a bit more tricky in patients who have avascular necrosis. You have to be able to do a pre-op X-ray and preoperative templating in order to do this. And you have to be able to do, I use X-ray intraoperative in order to judge not only leg length, but to also judge the offset position of the implants, both on the femoral side and the tibial side, and the femoral side. So on the cup side and on the femur side. Next slide, please. It is very important also to be able to template and know the sizes of the implants before starting. This is a prerequisite nowadays for patients who are having hip replacement. I think if you go in today and do a hip replacement without templating, you're asking for trouble. And you have to have the implants in theater, and you have to be aware of the probable sizes, one size up and one size down, in order to be absolutely certain of the implants that you're using. And preoperative templating is present now in almost most hospitals. I'm not aware of any hospitals that do not template for hip replacements. The next slide. This is my operative technique for the operation itself. So ideally, you'd want the patient as relaxed as possible to avoid muscle tension. So that gives you access, because you are going in an intramuscular plane without cutting the muscles. I use teicoplanin and gentamicin for antibiotic prophylaxis, one dose. It depends also on your local guidelines. I give 1 gram of tranexamic acid at the beginning and 1 gram at the end. If I use a catheter, then I would give them immediately after half an hour after the antibiotic administration. I use intraoperative X-ray, double layer of padding in the perineum to avoid any injuries, a well-padded ankle boot. I insist on the rep being in theater with the implants being prepared. I template beforehand, and I use the prepared instrumentation, and I use a femoral elevator to help me with the exposure of the femur. Next slide, please. And this is the traction device that I use, made out of the, as you can see from left to right, there's a bolster that helps to elevate the femur. There is a pole that goes in the middle between the legs to help with the traction. There's the ski boot, which helps to hold the leg. And this is what we use to manipulate the leg. And next slide, please. And this is the actual position of the patient inside theater with the right hip being planned and marked. And I double drape and obviously double prep before the operation. The size of the scar, although it doesn't really matter, but you're looking at around 10 centimeters scar on average, and you base it on the anterior superior iliac spine, 2 centimeters below and about 2 to 3 centimeters lateral. You feel for the tensor fasciae lata, and I base my incision based on that 10 centimeter incision. I can either extend it upwards or downwards. If you extend it downwards, that's mainly for acetabular preparation. If you extend it upwards, it's mainly for femoral preparation. But normally I aim to use a 10 centimeter incision, generally speaking, although the size of the scar is not the most important issue. It's the exposure, being able to do the operation safely. Next slide, please. I double drape, as I mentioned. So next slide. So I double drape, and I always have an assistant. With this, I don't wear the hood and the helmet because unfortunately the field is small, so it gets in the way. Next slide, please. I do landmarks. So I mark, this is the actual incision size. I mark everything before I start, and if I need to expose more, this is where I know that I'm going to extend the incision, and I know my limitations both superiorly, medially, and laterally. Next slide, please. And then it relies, the importance of this here is the retract position of retractors to help you expose the hip and get to the joint safely, and correct positioning in order to get the best exposure of the hip through the anterior approach. Next slide, please. Once we get to the capsule, we do a capsulotomy, slight traction on the hip itself, and then we do the femoral neck cut. I place a retractor behind the femoral head when I'm doing the neck cut to avoid any sort of the saw being limited by the retractor. And then the head is removed. And then you start the next slide, please. The actual beauty of this approach is you being able to ream under direct vision. So you can judge the way that you're reaming with the pelvis correctly positioned in a neutral position. You can then judge dynamically where you're putting your implant, how you're reaming, the depth of your reaming. And that's the beauty of this approach with the use of intraoperative X-ray, which has been shown in some recent literature to improve the positioning of the implant when you're doing it under X-ray guidance as well. And then hence we get good X-rays, good position of implants. As you can see, this is an acetabular component having been placed into the acetabulum, and then the next step would be to do the femoral side. The femur, next slide please. The femur is the more difficult component of this operation because you're basically reaming retrograde and you are trying to get into the hip in a more retrograde fashion, which sometimes can be a bit challenging, and hence the importance of having a femoral elevator and the correct retractors correctly positioned in the right position. And then once your femoral component is in, next slide please, you're then able to take intraoperative X-rays. I EUA the hip, put it through the full range of motion, compare it with the template that I've done, which is the second image, to see if I've placed the implant correctly. And then the full examination with an EUA to make sure that the hip is stable. And then I put the real implant in and also retest it again to make sure that it is in the correct position, take some X-rays, and those images are stored. It's a dynamic image, and it's reassuring to know that the X-rays are taken intraoperatively, so You don't have to wait for next day X-rays. The next day X-rays are just as a confirmation to confirm the position of the implants. Next slide, please. This is an example of a patient of mine who is a 67-year-old female who came to me with severe arthritis of the right hip. And these are the sort of X-rays that I aim to get by restoring leg length, offset, correct position of the acetabular component, and the correct position of the femoral component. And this is another example of another patient with a slightly abnormal anatomy, 73-year-old, next slide, please, 73-year-old gentleman who basically has slightly abnormal anatomy. And again, you aim to get good position of implants. And again, the same with regards to leg length, offset, and position of implants. And then finally, a more complex case with somebody with severe arthritis of both hips. Again, same thing, you're aiming to restore the anatomy as best as you can with the intraoperative images. Next slide, please. The post-op care, I recommend that they don't extend the hip beyond 20 degrees. Ideally, you should avoid external rotation rather than internal rotation beyond 50 degrees, as opposed to the posterior hip approach, where the hip flexion is limited not to go beyond 90 historically, and no internal rotation or adduction past neutral. I ask them to use crutches initially just to slow them down, and no crossing of the legs. And I tell them to keep their hips above their knees when sitting, and avoid sitting on deep chairs, although this is more or less historical nowadays. Next slide, please. These are my results. I've done my own comparison and study of my own outcomes, looking at blood loss, demographics, length of stay, pain scores, and definitely speaking from the outcome point of view, the length of stay is less by a day, which fits with the other history, with the other literature. The gait is better at analysis in the anterior approach than the posterior approach. One nerve injury to the lateral cutaneous nerve of the thigh, none obviously in the posterior approach. Less pain definitely on the pain scores, including the VAS, and also from an outcome point of view, the Oxford hip score at 6 weeks is slightly better in the anterior approach than the posterior approach. And these are some, next slide please, testimonials of patients who've had them. So the patients actually, the reason why this is popular is that the patients are happy, they do well, and they recover quickly, and they seem to be happy with the outcome overall. And because they make a good recovery quickly, they tend to give me good feedback, generally speaking, with regards to the outcome. And next slide, please. I've had a video testimonial as well, but so in summary, if you move to the next slide, please, David. This is a patient that we saw in the video is a patient who's had an anterior approach, and within 6 weeks I saw him, he's doing extremely well. The anterior approach is a minimally invasive anterior approach. It offers itself to a quicker recovery, but it is not without risks. There is a big learning curve. You have to have time and patience. I'd recommend that you use X-ray intraoperatively for the position of the implants. It does offer good outcomes. It does offer good patient recovery, quicker recovery, and a shorter rehabilitation. However, when we look at the patients at 12 months, there is no difference between the anterior and the posterior approach. If you are going to approach this, you need to attend courses specific for it, do a fellowship, and you have to have support from an implant company that specializes ideally in the anterior approach, offering you the right instrumentation and the right support. And I highly specify the importance of preoperative planning and templating and being prepared for the surgery. But it is a good approach, it's a neat approach, and it offers a good outcome specifically in the shorter term. Thank you very much for your time, and please feel free to fire away any questions. If you have any queries, please do not hesitate to contact me. My contact details are on there, my email and the work phone number. Thank you. I hope this was useful, and if there are any further questions regarding this, please feel free to email me, or I'm more than happy to discuss this in more depth. As I said, it is a good approach and it offers a good outcome, and I'll be happy to discuss it further or answer any questions regarding it.